Okay, so we are live. We are live and well enough. Okay, so anyone in the chat, please introduce yourself so we can have an interactive course. Hopefully we are more than usual. Okay, we will start in 5 minutes. Please let me know your names in the chat box. So, let me know your name in the chat box. And we will start in approximately 2 minutes. Hello Subhash, pleased to meet you. Hopefully you'll enjoy this course. Okay, so let's get going then. Today we are going to talk about cardiology and infectious disease. There are many questions in these two topics, but we will start with the most frequent ones. A 27-year-old patient diagnosed with HIV 3 years ago presents with thin arms and legs and excessive fat buildup in the neck. He says that 6 months ago he was put on a new drug. What is the drug he was switched to? A. Nevirapine, B. Dolutegravir, C. Ritonavir, and D. Abacavir. Please let me know your answer in the chat box so we can discuss afterwards. Okay, let's go to the next question. Namely, he states that the previous drug he used caused him a rash on the arm. He developed dysphagia and chronic cough due to the same drug. What does his genetic panel show? A. HLA-DQ2, B. HLA-DR3, C. HLA-B27, or D. HLA-B57. Once again, let me know your answers in the chat box. Okay, so the answer is C for the first one, namely ritonavir, and D for the second one, namely HLA-B57. Let's discuss a little bit the questions. Ritonavir is, as we can see here, a protease inhibitor. It is responsible for lipodystrophy, as the patient presented with thin arms and legs, but a buffalo hump. On the other hand, dolutegravir is an integrase inhibitor, and the other therapies such as abacavir is an NRTI. Now, the patient developed previously dysphagia, which can be eosinophilic esophagitis, chronic cough due to hypersensitivity pneumonitis, and a rash on the arm, again due to a topical disease, simply seen in patients with HLA-B57 treated with abacavir. If you want to have this table for reference, you can take a screenshot now. There are five classes of drugs that are part of HAART. Namely, the nucleotide reverse transcriptase inhibitors are represented by abacavir, emtricitabine, tenofovir, lamivudine, and zidovudine. There are some specific adverse drug reactions for these drugs. Hypersensitivity is seen with abacavir only if the patient has HLA-B57. On the other hand, zidovudine can cause anemia. Peripheral neuropathy and lactic acidosis, as well as bone marrow suppression, are typical for all NRTIs. The non-nucleoside reverse transcriptase inhibitors are represented by efavirenz and nevirapine on USMLE. An interesting side effect of efavirenz are vivid dreams and other CNS symptoms. By contrast, all NRTIs can cause rash and hepatotoxicity. The integrase inhibitors are largely represented by dolutegravir or raltegravir. The most common adverse drug reaction for integrase inhibitors is represented by an increased CK. The protease inhibitors such as lopinavir, ritonavir, and darunavir cause lipodystrophy, hyperglycemia, and diarrhea. And fulvirtide is responsible for causing skin infection and inflammation at the injection site. Are there any questions on this vignette? Please let me know if you have any questions on the previous vignettes. Hello Carlos, pleased to see you. I hope that many of the previous students rejoin. Now, let's go to the next one. We have a 30-year-old female that gave birth 2 days ago. The baby had an Apgar score of 9 at 1 minute and 10 at 5 minutes. Since then, she had a fever of 39 degrees Celsius with foul-smelling lochia. She delivered vaginally, comes from a wealthy family, and she has a positive Ferning test. What are the risk factors for this patient's condition? A. Vaginal delivery. B. High socioeconomic status. C. Young age. Or D. Premature rupture of membranes. Please let me know your answer in the chat box. Okay, so we have a D. Perfect. Let's see the other clinical vignette. After days of treatment, the patient develops spiking fevers over 40 degrees Celsius and abdominal and pelvic pain. Blood cultures are obtained and the CT scan is made. Aside from the usual antibiotics, what is the other management therapeutic? Low molecular weight heparin, ampicillin, or metronidazole? Once again, let me know your answer in the chat box. Okay, so we have D, and once again a D, metronidazole. There's also one question briefly mentioned, namely, what is the treatment she was given? If you have any idea, let me know in the chat box. Do we have any answer for the treatment that she received? Ampicillin, gentamicin. Almost. It is almost the right answer. Ampicillin is usually added to the IV antibiotic course of gentamicin plus clindamycin. Okay, let's see the answers. The first answer was D, premature rupture of membranes, and the second answer was B, heparin. Let's see what are the risk factors for postpartum infection. A low socioeconomic status, multiple vaginal exams, premature rupture of membranes, an emergency C-section, intrapartum manipulation of the uterus and of the fetus, young age for the female, the corticosteroid use, and bacterial colonization, either as group B strep. Now, the patient was actually treated for postpartum infection. As we saw, practically we treat it with gentamicin plus clindamycin, and if it is resistant, we add ampicillin. However, she developed a complication known as septic pelvic thrombophlebitis. This complication of postpartum infection presents as abdominal and pelvic pain with spiking fevers more than 40 degrees Celsius alternating with normal temperature. The diagnostic methods are represented by blood cultures and abdominal CT scans to identify a possible abscess. The treatment has the same antibiotic scheme as for postpartum infection, but it also has anticoagulation. Talking about anticoagulation in the postpartum period, this will be done with heparin for 7 to 10 days. Okay, are there any questions on these two questions? Okay, it seems that there are no questions. Let's pursue further with a break. So, if you want to support the growth of the channel, you can go on Patreon and actually become a patron. If you want to take a look into more USMLE educational content, then you can check the playlist below that will be added to the chat box. Okay, the last topic we will touch upon is a cardiology topic. We have a young athlete that presents with palpitations after his marathon. He is diaphoretic. His blood pressure is 120/80 with 80 beats per minute. After 10 minutes, the symptoms cease. The EKG made at 15 minutes from the presentation in the ED is the one by the side. What is the best next step in management? Send him home? Implant an intravenous pacemaker? Use a transcutaneous pacemaker? Or use beta blockers? Let me know your answer in the chat box. Okay, we have an A. Well done. Let us see the second question. Now we have a 65-year-old patient with COPD. He comes to the ED with palpitations. He says these episodes occur more frequently since he had the last COPD exacerbation 2 months ago. He has 36 degrees Celsius, 130/95, and 150 beats per minute. The EKG is shown below. Etiologic and symptomatic management of the patient fails. What is the best next step? We administer beta blockers. The patient undergoes catheter ablation. He receives antibiotics, or he is given albuterol and corticosteroids. Please let me know your answer in the chat box. Also try to expand on why you think this is the correct answer. Okay, we have a D, albuterol and corticosteroids. Interesting. Okay, so let's discuss them a bit. The first answer indeed is A, we send him home, and the second answer is catheter ablation. In the first case, this young athlete suffers from wandering atrial pacemaker. The wandering atrial pacemaker is a benign condition, in contrast with paroxysmal atrial tachycardia seen with this COPD patient. Indeed, albuterol and corticosteroids would be used if he would have an exacerbation as a first line. However, the clinical vignette states that etiologic and symptomatic management, namely albuterol and corticosteroid, has already failed. In the case of treatment-resistant patients with PAT, the last resort is represented by catheter ablation. Now, what are the common aspects for these two pathologies? What are the differences? Both have 3 different P-wave morphologies. Both have very varying PR lengths. The differences between wandering atrial pacemaker and paroxysmal atrial tachycardia revolve around the heart rate, namely, being a benign condition, the wandering atrial pacemaker has a heart rate of less than 100 beats per minute. By contrast, the paroxysmal atrial tachycardia presents with a heart rate between 100 and 250. Also, the paroxysmal atrial tachycardia has a warm-up and a cool-down period when the heart rate starts to accelerate, respectively to decelerate. The treatment for each condition varies. For a wandering atrial pacemaker, there is no treatment. Usually it is benign and only maybe observation. However, if the patient remains symptomatic for a long time, then a pacemaker may be warranted. In the case of paroxysmal atrial tachycardia, we have to treat the underlying etiology, such as COPD exacerbation. As Carlos said, we firstly add albuterol and corticosteroids. Then, if we have no success, we can go for beta blockers if we have problems with the ventricular rate. In the previous EKG, there was no ventricular rate problem. However, the medication failed. Then, if the medication fails, we use catheter ablation to ablate the aberrant circuits in the atrium. Are there any questions on this topic? So there are no questions on this topic. Then we will proceed further. Firstly, if you have any questions from this course, please let me know down in the comments or now in the chat box. Secondly, subscribe to be notified when we go live. And thirdly, if you see the rewind practically of this live stream, please let me know in the comments how would you like to see this live stream in the future. If you have any suggestions on improvements, write them in the comments. No, Carlos, the athlete had a wandering atrial pacemaker. On the EKG, there were various P waves. Look here. Here is another one. Let me see if I can show you more in a more clear fashion. This morphology differs from this one. And we also need a third one, like this one, where you can see much more. Yes, it is much more clear. It is clearer that the PR interval is longer than for the other two P's. So practically we have 3 P wave morphologies and a heart rhythm of less than 100, as the clinical vignette states that he has 80 beats per minute. Okay. Questions or suggestions for improving the live stream? With pleasure, Carlos. Okay, then if there are no questions or suggestions, I will leave you, and we will see each other next week, hopefully. If the month of live stream did not end. Okay, so have a nice weekend, and see you in the next one. Bye.